Welcome to the Deep Dive. Today we're taking a truly comprehensive plunge into a vital yet often vulnerable part of male anatomy, the testes and scrotum.
Mm-hmm.
These structures play such a crucial role in development and health, but their intricate pathways can sometimes take unexpected turns, leading to a range of conditions that really demand deep understanding.
Absolutely.
And for anyone aiming to, really master this area, whether that's in a clinical setting or maybe just out of profound curiosity, grasping the nuances from the subtle developmental hiccups to the sudden emergencies is just key.
That's exactly right. And our source material for this deep dive provides precisely the kind of detail needed for that level of mastery. We're extracting insights from a foundational surgical text, Bailey and Love's Short Practice of Surgery, focusing specifically on Chapter 86, the testes and scrotum.
Okay.
And this text, it doesn't just list conditions, it really delves into their pathology, their clinical presentation, and management with the sort of precision that allows for real deep understanding.
So our mission here is to go through the information presented in this text, pulling out every essential nugget of knowledge. We'll cover the full spectrum, starting with developmental issues like, say, undescended testes, moving into acute emergencies like torsion.
Right.
Exploring common swellings, infections, tumors, and trauma. The goal isn't just to skim the surface, but to get that deep, detailed understanding, equipping you, the listener, with knowledge on par with someone who needs to confidently apply this in the real world. Achieve that mastery.
Yeah, and achieving that level of confidence requires understanding not just the name of a condition, but the why behind its presentation, the critical factors influencing prognosis, and the rationale for specific investigations and treatments.
Makes sense.
So I'll be here to help translate the text descriptions into meaningful clinical insights, connecting the dots and highlighting what truly matters from the source material while you guide us through the journey.
Okay, let's get started then. Let's unpack this first major topic from the source material, which deals with a fundamental developmental anomaly. Incomplete descent of the testis, also known as cryptorchidism.
This is an excellent place to start, as it's rooted in the very process of how the body forms. The source text gives us a clear definition. Incomplete descent refers specifically to a testis that has been arrested at some point along its normal path of descent.
Okay.
Which is from its starting point near the kidney in the abdomen, down through the inguinal canal, and finally into the scrotum.
So it started on the right track, but got stuck somewhere along the way. And the source makes a very important distinction here, contrasting incomplete descent with an ectopic testis.
Yes, that distinction is crucial for understanding the underlying problem and, where you might find the testes. An ectopic testes isn't just arrested along the normal path, it's directed away from it entirely and ends up in an abnormal location. The text even references figure 86.1, which visually illustrates the normal descent pathway and highlights these various points of arrest or ectopic placement. Ectopic sites can be surprising. The text lists possibilities like the prepenile area, a transverse scrotal position where it crosses over.
Crosses over.
Yeah, exactly. Or the superficial ectopic pouch, which is actually the most common ectopic site, lying outside the inguinal canal or even down in the femoral triangle.
Wow. So either stuck or completely misdirected. How common is this condition then?
The incidence numbers provided in the source are quite specific and noteworthy. Approximately 3% of full-term male infants are born with incomplete descent.
3%, okay.
But here's where it gets particularly interesting. That number jumps significantly to about 30% in premature male infants.
30% in preemies, that's a substantial number. Does that mean a lot of them just resolve on their own after birth?
They often do, especially early on. The text indicates that roughly 2/3 of these undescended tests will spontaneously descend into the scrotum within the first 3 months of life. However, the crucial point is that full descent after that initial 3-month window is uncommon. By the age of 1 year, the incidence has typically dropped to around 1%.
So that first 3 months is a critical observational period. If it hasn't descended by then, it's unlikely to on its own.
Precisely. And the source also notes that this condition can sometimes be subtle enough to be missed during the neonatal physical examination, and only comes to light later, perhaps when complications develop. We'll dive into those complications shortly, but they can include things like an associated hernia, the development of pain, or even testicular torsion.
Okay.
And there's some evidence of a familial link. with a higher incidence reported in fathers, about 1.54%, and brothers, around 6% of affected individuals, suggesting a potential genetic predisposition.
Interesting. Let's talk about the pathology and where these tests are actually found if they don't complete their journey. The source gives us a breakdown by location.
It does. Incomplete descent is more common on the right side, and about 20% of cases involve both tests. While the development of secondary sexual characteristics is typically normal in adults with this history, the undescended testis itself might be noticeably smaller than the contralateral, normally descended testes by the time puberty is reached.
Right.
The source details the common locations of arrest along the normal path. About 15% are intra-abdominal, usually just inside the internal inguinal ring. Around 25% are within the inguinal canal, and these can sometimes be difficult or impossible to feel on examination.
Okay.
But the majority, about 60%, are extracanalicular or high scrotal, which means they've made it through the inguinal canal but are arrested just outside, high up near the neck of the scrotum.
So for most cases, the testis is actually quite close to the scrotum, just not fully in it.
That's right. The high scrotal or suprascrotal position is the most frequent point of arrest. And then you have the ectopic sites we discussed, with the superficial inguinal pouch being the most common ectopic location. Figure 86.1 in the text really helps visualize this spectrum of possibilities.
What happens to the testis itself over time if it remains in one of these higher than normal positions? Does it get damaged?
This is where understanding the microscopic changes is critical because it directly informs the timing of management. The source highlights that these changes become apparent relatively early, from as young as 1 to 2 years of age.
That early?
Yeah. What happens microscopically? Well, the text describes the loss of Leydig cells, degeneration of Sertoli cells, and a progressive decrease in spermatogenesis, the process of producing sperm.
Okay.
Importantly, the higher the position of the testis, the greater the degree of this histological change. This really reinforces the urgency behind why early intervention is recommended.
Okay, this brings us to the really critical part, the so what for the listener. What are the truly significant consequences of untreated or delayed treatment of incomplete descent? These aren't just minor issues, are they?
Absolutely not. These consequences are major and have long-term implications, which the source details and summarizes effectively in summary box 86.1. First, there's the significant risk of infertility.
Right.
Men who have had undescended testes have a higher likelihood of reduced fertility, even if the testes is surgically brought down later, orchidopexy.
Does having one or both tests undescended make a difference to fertility prospects?
It does. The source notes that in men with unilateral undescended testes treated with orchidopexy, the infertility rate is not believed to be significantly different from the general population.
Okay, so one isn't too bad then.
Relatively speaking, perhaps. However, for men with bilateral cryptorchidism, there is a documented fertility reduction of about 38%, even after successful orchidopexy.
38% reduction, even with surgery. That's significant.
It is. And strikingly, the source states that patients with bilateral undescended testes who undergo orchidopexy as adults are almost universally infertile and azoospermic.
Wow.
Meaning they have no sperm in their ejaculate, although assisted reproductive techniques might offer some possibilities in these cases.
That near certainty of infertility for bilateral cases treated in adulthood is a stark outcome. Does the timing of the surgery make a difference to that fertility outcome? Is that why early surgery is pushed?
Yes, profoundly. The source strongly emphasizes that the primary rationale for recommending early surgery, typically between 6 and 18 months of age, is precisely to mitigate the progressive degeneration of spermatogenic tissue and the reduction in spermatogonia counts that starts to occur after the second year of life in testes remaining in a non-scrotal position.
Got it.
Performing the surgery early aims to preserve as much of that potential as possible.
Beyond fertility, there's also a well-established increased risk of testicular cancer.
This is the other major consequence, and it's a serious one. The lifetime risk of developing testicular cancer is significantly elevated in individuals with a history of cryptorchidism.
How much higher is the risk?
The source quantifies this risk. If orchidopexy is performed before puberty, the risk is around 2 to 3 times that of the general male population. However, if the surgery is delayed and performed after puberty, that risk jumps significantly to 5 to 6 times higher.
5 to 6 times.
Yes. Interestingly, the source notes that the precise timing of surgery within that prepubertal window, whether very early in infancy or later childhood, doesn't appear to significantly alter the subsequent malignancy risk as long as it's done before puberty hits.
Okay. What type of testicular cancer are they most likely to develop?
In untreated undescended tests, the most common histological type of cancer is seminoma, which typically occurs in men aged, say, 15 to 45 years.
Right.
However, after successful orchidopexy, the pattern shifts slightly, and seminomas represent only about 30% of the testicular tumors that subsequently develop in these previously undescended testes.
So the risk remains, even if the testis is brought down, and the type of cancer might be different. Is this cancer generally treatable? Can anything be done?
It is, generally with a very good prognosis, if detected and treated early. And the source includes a vital, practical piece of advice here for you, the listener, and for anyone caring for a boy who's had orchidopexy. These individuals should be taught testicular self-examination as they grow older.
Self-checks. Makes sense.
This proactive approach can lead to earlier detection if a tumor does develop.
The source also points out a high association with hernias.
Yes, that's frequently encountered. The text states that up to 90% of boys with an undescended testis have a patent processus vaginalis.
90%.
Yeah, that persistent connection to the abdominal cavity that usually closes off. While not all of these develop into clinically obvious hernias that you'd feel or see, the anatomical potential is certainly there.
And finally, an increased risk of testicular torsion, which you mentioned we'll cover more in depth later.
Exactly. The undescended testis is anatomically predisposed to twisting on its cord, often lacking the normal fixation mechanisms that prevent this in a scrotal testis. The source lists this as another key consequence in summary box 86.1, alongside infertility, malignancy, and hernia. Understanding these risks is fundamental to appreciating why we intervene.
Okay, let's pivot to diagnosis then. How do you physically examine a child to identify this condition? And crucially, how do you distinguish it from something that looks similar but isn't a true undescended testis? Like, how do you nail the diagnosis?
The physical examination is absolutely critical, and the source provides important clinical guidance. To get the best chance of palpating the testis, if it's present but not in the scrotum, you need to ensure the boy is relaxed and in a warm room.
Warm room, okay.
Examining them in a supine lying down position is often recommended. The warmth and relaxation help to minimize the cremasteric reflex.
The cremasteric reflex, that's key to the differential, isn't it? What exactly is that?
It is. In young boys, the cremaster muscle is quite active, and stroking the inner thigh or even just cold can trigger it to pull the testis upwards. This brings us to the major differential diagnosis, the retractile testis.
Ah, the retractile one.
A retractile testis is located in the scrotum sometimes, but due to this overactive reflex, it can easily be pulled up into the inguinal canal temporarily.
So how do you tell if it's genuinely stuck up there or just temporarily pulled up by that reflex?
The source gives us clear differentiators, which are essential clinical skills. With a retractile testis, the scrotum is usually normal and well developed. This is in contrast to the often underdeveloped or hypoplastic scrotum seen on the affected side with a true undescended testis. You'd see this illustrated in figure 86.2 in the text, showing that lack of scrotal development.
Okay, so the scrotum looks different.
Yes, and the key physical maneuver is this. A retractile testis can be gently manipulated or milked down from the inguinal region all the way to the bottom of the scrotum, and it will often remain there for a few moments before retracting again. A true undescended testis, however, cannot be brought fully down into the scrotum with gentle manipulation. This is a critical clinical distinction.
That gentle manipulation test sounds vital. What's the management if it is indeed a retractile testis?
Yep.
Do you just leave it?
According to the source, retractile testes do not require surgical treatment. The key is recognizing them for what they are: highly mobile, but ultimately capable of residing in the scrotum. However, the source recommends yearly physical examinations for boys with retractile testes. This is because there is a reported risk, cited as ranging widely from 2% to 50%, depending on the study, of a retractile testes becoming an acquired undescended testes later in childhood or adolescence.
Oh, so it can get stuck later.
Yes, meaning it eventually gets stuck above the scrotum permanently. This is captured in summary box 86.2. So follow-up is important.
Okay, back to the truly undescended testes. You mentioned that about 70% are palpable. What about the roughly 30% that aren't? How do you manage the non-palpable testes?
The non-palpable testis presents a real diagnostic challenge. When you can't feel the testis on physical examination, you need to determine if it exists at all, and if so, where it's located. It could be intra-abdominal in the inguinal canal, but unable to be felt, or maybe truly absent.
What about imaging to help locate these? Ultrasound, CT.
The source discusses imaging options, but is pretty clear about their limitations. Ultrasound is often used, and it has a high positive predictive value if it does detect a testis, particularly if it's in the inguinal canal.
Okay.
But its sensitivity, meaning its ability to find all non-palpable tests, including those hiding in the abdomen, is only around 45%. So a negative ultrasound doesn't rule out an intra-abdominal testis.
Right, not foolproof.
Exactly. And CT scanning, well, the cost and radiation exposure are generally prohibitive, especially for children. MRI offers better sensitivity and specificity than ultrasound for locating tests, but it's also more expensive, less readily available, and often requires anesthesia in young patients to ensure they stay still enough for the scan.
So no imaging test is guaranteed to find it or rule it out.
Correct. The source makes a critical statement. No radiological test can conclude with 100% accuracy that a testis is truly absent. Because of these limitations and the need for definitive diagnosis and, well, potential treatment, laparoscopy has become the recommended gold standard diagnostic method for a non-palpable testis.
Laparoscopy. Why is that the gold standard?
Because it's not just a diagnostic tool, it's often therapeutic in the same setting. A small incision is made, a camera's inserted.
Keyhole surgery.
Exactly. You can directly visualize the abdominal cavity and pelvis. You can see if a testis is present inside the abdomen. You can see where the vessels go, or if there's maybe no testis development at all. And if a testis is found, surgery to bring it down can often proceed immediately through the laparoscope or with a minimal conversion to open surgery.
Okay, let's move on to the actual management and treatment then. You mentioned medical versus surgical options earlier. Any role for hormones?
For medical treatment, the source mentions hormonal therapy, typically involving human chorionic gonadotropin, HCG. However, the text states there is little current evidence supporting its use to induce testicular descent.
So it doesn't really work.
Response rates are low, often no better than placebo in studies, and there's a lack of evidence for long-term efficacy. So, based on this text, hormonal therapy is generally not recommended as a primary treatment.
So surgery, specifically orchidopexy, is the standard.
Yes, surgical treatment, the orchidopexy is the mainstay. This procedure involves mobilizing the testes and spermatic cord, gaining sufficient length, and then repositioning the testes securely within the scrotum.
And the timing is key, as we discussed earlier regarding the microscopic changes and consequences. That 6 to 18-month window.
Absolutely. The source recommends performing orchidopexy usually between 6 and 18 months of age, using the corrected age for infants born prematurely. The primary goal of this timing is to prevent those critical long-term consequences, particularly minimizing the damage to spermatogenesis that accelerates after the second year of life if the testis remains in a non-scrotal environment.
Can you walk us through the general surgical approach described in the source? How do they actually do it?
The standard operation is performed through a short incision, typically made in the groin area over the deep inguinal ring. The surgeon exposes the inguinal canal by dividing the external oblique aponeurosis, which is a layer of tissue in the abdominal wall.
Okay.
The challenge then is to gain enough length in the spermatic cord, which contains the vas deferens and testicular blood vessels, to comfortably bring the testis all the way down to the bottom of the scrotum without tension. The source describes specific surgical steps or maneuvers to achieve this length.
The 3 maneuvers. That sounds very specific to the technique. What are they?
They are indeed crucial steps in this procedure. First, the surgeon identifies, separates, and ligates any patent processus vaginalis, that persistent connection to the abdomen, effectively closing it off and addressing the associated hernia risk.
Right, fix the potential hernia too.
Exactly. Second, they divide the coverings of the spermatic cord, including the cremasteric muscle fibers, which can shorten the cord. And third, they carefully divide any lateral fibrous bands that might be tethering the cord near the internal inguinal ring.
It sounds like a delicate balance between freeing the cord and protecting its vital structures, the vessels and the vase.
It absolutely is delicate work. The source explicitly notes that the tiny vas deferens and the fine testicular blood vessels are vulnerable to injury during these mobilization steps, so meticulous surgical technique is required. Once sufficient length is obtained using these maneuvers, the surgeon prepares a space in the scrotum. They stretch the empty hemiscrotum with a finger passed through the inguinal incision to make room, and then create a pouch between the dartos muscle, the layer just beneath the scrotal skin, and the skin itself.
A little pocket for it.
Precisely. The testes is then placed and secured within this pouch, often using temporary sutures to hold it in place. Figure 86.3 in the text illustrates the placement of the testes in this constructed pouch.
Is it ever necessary to remove the undescended testes instead of bringing it down? An orchidectomy.
Yes, orchidectomy, the removal of the testes, is a consideration in specific situations. The source suggests this should be considered if the incompletely descended testes is found to be atrophic, meaning significantly underdeveloped or unhealthy looking.
Okay.
It's also strongly considered if there's a suspicion of malignancy, particularly in an older postpubertal boy, and especially if the other testes is normal. Given the increased lifetime risk of cancer, removing a testes that is already likely abnormal might be the safer option in certain cases.
What about managing those non-palpable tests found via laparoscopy? You mentioned laparoscopy as the gold standard diagnostic. What happens next if a testis is seen inside the abdomen?
For testes found inside the abdomen during laparoscopy, the source outlines several surgical options, often performed laparoscopically. There's a standard laparoscopic orchidopexy where the testes is carefully dissected, free from surrounding tissues, and the cord is mobilized to bring it down while preserving the main testicular vessels.
Right.
But for higher abdominal tests where getting enough length with the primary vessels intact is challenging, techniques involving dividing the main testicular vessels are used.
It sounds counterintuitive, dividing the main blood supply. How does that work?
It does, but it relies on collateral blood supply. This is where the Fowler-Stevens orchidopexy comes in, named after Robert Fowler Jr. and Frank Douglas Stevens, whose landmark 1959 paper described this approach. It involves dividing the main testicular vessels high up near their origin and relying on the collateral blood supply that travels along the vas deferens to keep the testes alive.
Okay, so there's a backup supply.
Essentially, yes. This can be done as a one-stage procedure where the vessels are divided and the testis is brought down immediately on the vas pedicle, or as a two-stage procedure.
2 stages.
Yes, where the vessels are divided and clipped first, and the final dissection and pull-down are delayed for about 6 months. This delay allows time for the collateral vessels along the vas to develop more robustly, increasing the chances of testicular survival when it's brought down in the second stage.
Fascinating technique. And if laparoscopy reveals no testis at all, is it just missing?
If no testes is visible during the laparoscopic exploration, the surgeon needs to try and determine if it never developed, which is true agenesis, or if it developed but then atrophied or disappeared. A vanishing testis. Yes. This is done by carefully looking for the structures that would normally be associated with the testes, the testicular vessels and the vas deferens. The source notes that finding blind-ending testicular vessels, or perhaps a little testicular nubbin high up, suggests a vanishing testis, likely due to prenatal torsion. True agenesis is rarer. The source cautions that the vas deferens isn't always a reliable indicator of the gonad's presence in these complex cases.
Okay.
If the internal inguinal ring is closed, but vessels seem to enter it, a scrotal exploration is typically done to look for a nubbin down there. If vessels enter an open inguinal ring, the testes might have been pushed into the abdomen, or an inguinal scrotal exploration might still be needed to confirm its absence. Laparoscopy is really crucial for distinguishing between these possibilities and intra-abdominal maldescent.
So vanishing testes implies it was there initially but then disappeared.
Exactly. The term vanishing testes describes the scenario where the testes developed normally early in utero, but then disappeared before birth, most likely due to prenatal torsion of the spermatic cord, cutting off its blood supply. True agenesis, where the gonad simply never formed, is a distinct and rarer entity. Laparoscopy is key to differentiating these from a testes that simply hasn't completed its abdominal or inguinal descent.
That gives us a really thorough picture of cryptorchidism, from its definition and incidence to the detailed consequences, examination, investigation, and the various surgical approaches, including the intricacies of the Fowler-Stevens procedure. Really gets into that mastery-level detail.
Understanding this condition at this depth is crucial for predicting risks, guiding timely intervention, and counseling patients and families. It's a foundational piece for mastering male genitourinary conditions.
Speaking of urgent problems, few are as time-critical as our next major section, torsion of the testes. This sounds like a true surgical emergency.
It absolutely is, perhaps one of the most time-sensitive surgical emergencies you'll encounter in this area. The source defines testicular torsion as the twisting of the spermatic cord and its contents, including the blood vessels supplying the testicle. When this twisting occurs, it rapidly compromises the blood supply, and if it's not corrected quickly, the testicle will die due to lack of oxygen and nutrients. It's that serious.
The clock starts ticking immediately then.
It does, and this is the central message from the source regarding torsion management. The earlier surgical intervention can be undertaken to untwist the spermatic cord and restore blood flow, the higher the probability of salvaging the testicle. Time is testes, as they say.
How frequently does this happen?
The source provides specific incidence figures, noting it occurs at a rate of about 3.8 per 100,000 males under 18 years of age annually. It's a significant cause of acute scrotal pain in children and adolescents, accounting for maybe 10-15% of cases presenting with acute scrotal disease in this age group.
Why does it happen in some individuals and not others? The source suggests it's uncommon in normal testes.
That's right. A normally developed testes is quite well anchored within the scrotum by the tunica vaginalis, which limits its ability to rotate freely. The source distinguishes between two types of torsion based on anatomy. First, there's extravaginal torsion.
Okay.
This occurs almost exclusively in neonates. In newborns, the tunica vaginalis isn't fully fixed to the scrotal wall yet, allowing for greater mobility of the testes within the scrotum, making it prone to twisting the cord above the tunica.
And the more common type seen in adolescents.
That's intravaginal torsion. The source explains this usually occurs due to a combination of anatomical variations that increase the testes mobility within the tunica vaginalis. The most common underlying factor, particularly in adolescents, is a high investment of the tunica vaginalis on the spermatic cord.
High investment.
Yeah, meaning the tunica attaches higher up on the cord, allowing the testicle to hang freely inside it, like the clapper inside a bell. This anatomical variant is known as the bell clapper deformity, and it's typically bilateral.
Oh, right. So you mentioned that before. It means the other side is at risk, too.
Exactly. Which is critical for management. Figure 86.4b illustrates this deformity. Other factors contributing to intravaginal torsion include inversion of the testis, sitting upside down, and separation of the epididymis from the main body of the testis, allowing the testes to twist on its connecting pedicle. Figure 86.4c shows that.
So it's often an underlying anatomical predisposition. What actually triggers an episode of twisting? It's a specific event.
The source points to sudden contraction of the cremaster muscle. This muscle, which attaches to the testes, contracts reflexively in response to cold, touch, or excitement. The spiral attachment of the cremaster fibers can, in someone with an anatomical predisposition like the bell clapper deformity, favor the rotation of the testes around its vertical axis when it's pulled sharply upward. This is why torsion can sometimes be precipitated by straining, lifting heavy objects, sexual activity, or engaging in sports.
You mentioned time is critical. How rapidly does the testes sustain damage? Is there a clear cutoff?
Damage is determined by two main factors. The degree of twisting. A 720-degree twist compromises blood flow faster than a 360-degree twist. And, most importantly, the duration of the torsion.
Okay.
This is where the timing becomes paramount. The source gives a stark, unforgettable timeline. If the testes can be surgically untwisted and blood flow restored within 6 hours of the onset of symptoms, there's nearly a 100% chance of testicular salvage.
6 hours, 100%.
Okay. However, if surgery is delayed for 24 hours, the salvage rate plummets dramatically to only 20%.
Wow. That difference between 6 hours and 24 hours is incredibly impactful. It really drives home the emergency nature.
It is the absolute core principle of managing suspected torsion. Every minute counts. The source does note that occasionally torsion can spontaneously untwist, leading to transient severe pain. This phenomenon is termed intermittent testicular torsion and should be considered a possible cause of recurrent self-resolving testicular pain in adolescents.
Yeah.
However, the risk of retorsion is high and it still warrants investigation.
What are the classic clinical features that should immediately raise suspicion for torsion? What does the patient experience?
Testicular torsion is most common in the age range of 10 to 25 years, though it can occur at any age. The hallmark presentation is the sudden onset of severe pain, often radiating to the groin and lower abdomen.
Sudden and severe.
Yes. This pain is often accompanied by systemic symptoms like nausea and vomiting. On physical examination, the scrotum on the affected side is typically swollen and exquisitely tender. Initially, the scrotal skin may look normal, but with increasing duration, it can become red and edematous. The patient is usually not feverish, at least in the early stages.
And when you examine the testes itself?
Specific findings on palpation include the testes being swollen, very tender, and often appearing to be positioned higher within the scrotum than the unaffected side. Sometimes you can feel the tender, thickened, twisted spermatic cord above the testes.
And you mentioned the cremasteric reflex again earlier. Is that absent here?
Yes, and the loss of the cremasteric reflex is a key diagnostic sign highly suggestive of torsion. Normally, stroking the inner thigh causes the ipsilateral testes to be pulled upward by the cremaster muscle. If the spermatic cord is twisted, this reflex arc is interrupted or mechanically prevented, and the testes does not elevate. Its absence is a strong clinical indicator pointing towards torsion rather than inflammation.
Okay, given the severity and the need for rapid action, what are the important differential diagnoses to consider when a patient presents with acute scrotal pain? What else looks like this?
Distinguishing testicular torsion from other causes of acute scrotal pain is crucial because the management is completely different. The source highlights several key differentials. Epididymo-orchitis, or inflammation of the epididymis and testes, can cause pain and swelling.
Right, infection.
It might be associated with scrotal skin redness and sometimes a mild fever, which could potentially be confusing. However, epididymo-orchitis is often associated with symptoms of a urinary tract infection or sexually transmitted infection, like dysuria, painful urination.
Is there a way to tell the difference on exam?
A classic, though sometimes unreliable, differentiating sign, often referred to as preen sign, although the source doesn't name it, it describes the principle, is that elevating the testes reduces the pain in epididymo-orchitis because it relieves tension on the inflamed structure.
Okay.
Whereas elevating the testes typically worsens the pain and torsion due to pulling on the twisted cord.
That difference in pain response to elevation is a useful clinical clue. What else might mimic torsion?
Torsion of a testicular appendage is another common cause of acute scrotal pain, particularly in pre-adolescent boys. The most frequent culprit is the appendix of the testes, also known as the hydatid of Morgagni, named after Giovanni Battista Morgagni.
Okay.
Clinically, it can be very difficult to distinguish this from early testicular torsion with certainty. Sometimes, if you stretch the scrotal skin tightly over the area of maximum tenderness, you might be able to see a small dark spot, sometimes called the blue dot sign, which is the infarcted appendage.
A blue dot.
Yeah. If the diagnosis of twisted appendage is certain based on clinical exam and perhaps ultrasound, conservative management with pain relief is sufficient. However, the source is very clear. If there is any doubt whatsoever that the pain could be due to testicular torsion, surgical exploration is indicated to rule it out and remove the twisted appendage if found.
Better safe than sorry.
Absolutely. Other differentials include mumps-orchitis, which is inflammation of the testes caused by the mumps virus, typically occurring in postpubertal males as the parotid gland swelling is subsiding. In mumps-orchitis, the spermatic cord is not thickened, and it's often bilateral.
Okay.
There's also idiopathic scrotal edema, described by the source as an oddity seen in boys aged 4 to 12 years. The scrotum becomes very swollen and erythematous, figure 86.5, often bilaterally and extending to the perineum and penis, but crucially, there is little pain or tenderness.
Little pain, that's the key difference.
Exactly, which is a key differentiator from torsion. It's thought to be an allergic reaction and often resolves spontaneously within a day, although it can recur. Finally, though rare, a small, very tense, strangulated inguinal hernia compressing the spermatic cord structures can occasionally present with pain that mimics torsion.
So given the critical 6-hour window, how is the decision made about management? Does imaging play a role, like ultrasound?
The source emphasizes that the decision to intervene surgically should be made primarily on clinical grounds, while Doppler ultrasound scanning, which uses the principle described by Christian Johann Doppler to detect blood flow, can be used to evaluate blood supply to the testis. Figure 86.6 shows absence of flow.
Right.
The source explicitly states that false positive results can occur, and therefore ultrasound is not routinely recommended or necessary if clinical suspicion for testicular torsion is high.
So if you suspect it clinically, you don't wait for imaging. You go straight to surgery.
Exactly. The source reiterates the critical rule. If there is any doubt based on the clinical examination, urgent surgical scrotal exploration is indicated. The paramount importance of that 6-hour window for salvaging the testis means that an early urological surgical consultation must be obtained immediately upon a patient presenting with suspected torsion without delaying for imaging if the clinical picture is convincing or uncertain. Time is of the essence. Time is testis.
What happens during the surgical exploration? What does the surgeon do?
Surgical exploration is performed through either a transverse or midline incision on the scrotum. The surgeon examines the testis and spermatic cord. If torsion is found and the testis appears viable, meaning it's pink and feels healthy after untwisting the cord, the twisted cord is untwisted.
Okay, first untwisted.
Yes. Then, to prevent it from twisting again, the testis must be surgically fixed to the scrotal wall. The source specifies this is done using 3 non-absorbable sutures placed between the tunica albuginea, the tough outer covering of the testes, and the scrotal rapha, the midline seam of the scrotum.
Why non-absorbable sutures specifically?
The source specifies non-absorbable sutures because using absorbable sutures carries a significant risk that the fixation will loosen or disappear over time, allowing recurrent torsion to occur in the future. Non-absorbable sutures provide a more permanent fixation.
And you fix just the affected testes? Or both?
No, this is another absolutely critical step. The source mandates that the contralateral testes must also be fixed at the same time, even if it's asymptomatic and appears normal.
Even the good one. Why?
Because the underlying anatomical predisposition, such as the bell clapper deformity, is typically bilateral. If one testis is susceptible to torsion, the other one is also at high risk and requires preventative fixation to avoid a future emergency. You have to protect the other one.
Makes perfect sense. How does the surgeon determine if a testis is viable after untwisting, especially if it still looks questionable, maybe a bit dusky?
If there's clinical doubt about the testis' viability after untwisting, the source suggests wrapping the testis in a warm saline-soaked swab and observing it for a few minutes. Sometimes, making a small, shallow incision in the tunica albuginea can help. If there's bright red arterial bleeding from this incision, it strongly suggests the testis has survived and has a good chance of recovery.
And if it's clearly not viable, if it looks dead, what then?
An infarcted, non-viable testes, typically appearing dusky or black, must be removed via orchidectomy to prevent infection and other complications. The patient can then be counseled later about the option of having a testicular prosthesis inserted for cosmetic purposes if they wish.
What if a patient presents very late, say several days after the pain started? Is there any point operating then?
In cases where the duration of pain is several days or more, the affected testes will almost certainly be irreversibly damaged and non-viable. The source states it's not possible to recover such a testis. While immediate exploration offers little chance of salvaging the affected testis, except possibly pain relief from detorsion, it is still necessary to explore the scrotum to confirm the diagnosis and, crucially, to perform preventative fixation of the contralateral testis due to that inherent bilateral risk.
So you still operate, mainly for the other side. Does the patient need to be aware that removal is a possibility before the surgery?
Yes. The source advises that the patient, or parents, for a child, should be comprehensively counseled and provide consent for the potential orchidectomy before proceeding with surgical exploration, given that the possibility of finding a non-viable testis requiring removal exists, especially if they present later. Summary Box 86.3 effectively summarizes these critical points regarding testicular torsion management.
That covers the acute emergency with incredible clarity and urgency. Let's shift gears now to some common, less acute scrotal swellings. First up from the source, varicoceles. What is that exactly?
A varicocele is a very common condition, defined by the source as an abnormal dilatation and enlargement of the veins of the spermatic cord, specifically the pampiniform plexus, which is the network of veins that drain the testes. Basically, varicose veins of the scrotum.
Varicose veins, okay. How common is it and why is it almost always on the left side? You hear that a lot.
It's indeed common, estimated to affect maybe 10-20% of adult males. And you're right, about 90% of varicoceles occur on the left side.
90%.
Yeah. The source clearly explains the anatomical reason for this striking asymmetry. The left testicular vein drains into the left renal vein, which is a relatively high-pressure system. In contrast, the right testicular vein drains directly into the inferior vena cava, which is a lower-pressure system, and it does so at an angle below the right renal vein.
Ah, the plumbing again.
Exactly. This anatomical difference in venous drainage patterns predisposes the left side to venous pooling and dilatation. If a left varicocele is identified, there's also a 30-40% probability that a smaller, less apparent varicocele is also present on the right side.
So it's a plumbing issue related to venous pressure and drainage. When do they typically become apparent?
They are unusual in prepubertal boys and typically develop during late childhood and adolescence, which is a period of significant hormonal and vascular development in the testes. While they are present in 15-20% of the general male population, they are found in a much higher proportion, around 40%, of men presenting for evaluation of infertility.
That association with infertility is a key point, isn't it? Let's explore the pathophysiology more deeply. Why do they form?
The source discusses the structure of the pampiniform plexus and its role in draining the testes. Regarding the cause, it presents three main theories.
Okay.
1. The most widely accepted theory relates to the absence or failure of competent anterior flex valves, particularly at the junction where the left testicular vein meets the left renal vein, or the right testicular vein meets the IVC. Incompetent valves allow retrograde flow and pooling of blood.
Leaky valves.
Pretty much. 2, the nutcracker effect. This occurs on the left side where the left renal vein into which the testicular vein drains can be compressed between the superior mesenteric artery and the aorta. This compression can impede flow and increase pressure in the left testicular vein, contributing to varicocele formation.
Like a nut in a nutcracker.
Exactly. And 3, less commonly, angulation at the junction of the left testicular vein and the left renal vein is proposed as a factor. The source also mentions that there can be alternative drainage pathways via the cremasteric veins, but these aren't always sufficient to prevent dilatation if the main venous pathway is compromised.
Are there any other less common causes for varicocele? Something more serious?
Yes, while most are idiopathic, primary, secondary causes exist and are important to recognize, obstruction of the testicular vein by an external mass, such as a renal tumor or a retroperitoneal lymph node, can cause a varicocele, particularly in older men, or if the varicocele develops suddenly. A key clinical clue for a secondary varicocele due to obstruction is that it typically does not decompress or dissipate when the patient lies down, which is characteristic of primary varicoceles.
So if it doesn't go away lying down, that's a red flag.
It is. An isolated right-sided varicocele is also rare, and its presence should strongly prompt investigation with imaging like a kidney ultrasound to rule out a retroperitoneal mass. Rarer causes include deep vein thrombosis, renal arteriovenous malformations, or pampiniform plexus thrombosis.
What symptoms do patients with varicoceles typically experience? Is it painful?
Interestingly, most varicoceles are asymptomatic and are only detected incidentally during a physical exam. When they do cause symptoms, it's typically in adolescence or early adulthood. The most common complaint is a dragging discomfort or a dull ache in the scrotum.
A dragging feeling.
Yeah, which is often worse on standing for prolonged periods or at the end of the day, and usually improves when lying down.
And on examination, what do you find? What does it feel like? Examination
is best performed with the patient standing. On inspection, the affected side of the scrotum often hangs lower than the other. Figure 86.7a shows this. On palpation, the dilated venous plexus feels distinctive. The classic description is feeling like a bag of worms behind and above the testes.
Bagworms, okay.
If you ask the patient to perform a Valsalva maneuver, strain down, the varicocele may become more prominent, and you might even feel a cough impulse transmitted down the cord. When the patient lies down, the hydrostatic pressure is reduced, and the veins typically empty, making the varicocele much less palpable or invisible, which allows for better assessment of the underlying testes. In cases of long-standing significant varicoceles, the affected testes may feel smaller and softer than the opposite side, indicative of testicular atrophy.
How does ultrasound help in diagnosing varicoceles?
Ultrasound is a useful diagnostic tool, especially for confirming smaller or subclinical varicoceles that might be difficult to feel definitively. Figure 86.7b illustrates this. It's also crucial in those specific situations where you need to investigate a potential secondary cause, such as evaluating the kidney and retroperitoneum in cases of an isolated right-sided varicocele or a recent onset varicocele in an older man to exclude a renal tumor or other mass.
The source classifies varicoceles clinically based on palpability. What are the grades?
Yes, there's a grading system based on physical examination. Subclinical, not palpable or visible, but detected only by imaging like Doppler ultrasound. Grade 1, palpable only during a Valsalva maneuver. Grade 2, palpable at rest but not visible on inspection. Grade 3, visible and palpable at rest, the full bag of worms effect.
Okay, let's revisit that link between varicoceles and infertility in more detail. The source mentions they are common in men with abnormal semen analysis. Why is that?
This is one of the primary reasons varicoceles are treated. While only 10-20% of adult men have varicoceles, they are present in over 25% of men with abnormal semen analysis and in up to 40% of men presenting for infertility evaluation.
So a definite association.
Yes. The exact mechanism isn't fully understood, but the most accepted theory links the impaired sperm production to increased temperature. The dilated veins in the varicoce lead to increased blood flow and venous pooling around the testes. This results in chronically higher intertesticular temperatures compared to a normal scrotum.
It overheats the system.
Basically, yes. And the testes is exquisitely sensitive to temperature changes. This elevated temperature is thought to impair spermatogenesis. Large varicoceles may also affect Leydig cell function, potentially leading to lower serum testosterone levels. The source also notes that varicoceles can decrease sperm nuclear DNA integrity, which is associated with poor sperm motility, viability, counts, and morphology.
What does the medical evidence say about treating varicoceles to improve fertility outcomes? Is it always successful? Should everyone with one get it fixed?
The source references a 2012 Cochrane review, which concluded there is some evidence that treating a varicocele in men from couples experiencing otherwise unexplained subfertility may improve their chances of spontaneous pregnancy.
Okay, some evidence for unexplained subfertility.
Right. However, it also notes that varicocele repair is considered ineffective for increasing spontaneous pregnancy rates in men with subclinical varicoceles or those who have normal semen parameters despite having a varicocele.
So not for everyone.
No. The source mentions that varicocelectomy may improve outcomes when used in conjunction with assisted reproductive techniques, ART, for men with abnormal sperm parameters.
So treatment isn't universally recommended for every varicocele, but it has a specific role in certain cases of infertility.
Precisely. The current consensus, reflected in the source, is that treatment is generally indicated for men with a palpable clinical varicocele, grade 1 or higher, a low sperm count or abnormal semen parameters, and who are part of a couple experiencing unexplained infertility. The source also cautions against unnecessary treatment in adolescents with varicoceles, as the vast majority will not experience fertility issues later in life, and intervention carries potential risks. Treating large symptomatic varicoceles primarily for pain relief is a separate indication, of course.
If treatment is indicated, what are the main approaches? How do you fix it?
For symptomatic varicoceles causing significant discomfort, or for fertility indications, there are two main approaches. Percutaneous embolization of the gonadal veins is often the first-line option, as it's less invasive than surgery.
Embolization, like blocking the vein.
Exactly. This involves accessing the vein, often through a groin or neck vessel, and using coils or a sclerosing agent to block the dilated veins. However, the source notes that varicoceles recur in about 20% of cases after embolization.
20% recurrence. What's the alternative?
If embolization is not technically possible, or if there is a recurrence after embolization, surgical ligation of the testicular veins is the appropriate treatment.
And what are the surgical options?
Surgical ligation can be performed via different approaches, inguinal, subinguinal, or laparoscopic. The source highlights that current evidence indicates microsurgical varicocelectomy, performed using an operating microscope, is generally considered the most effective surgical method.
Microsurgery. Why is that better?
This approach allows for precise identification and ligation of the dilated veins while sparing the testicular artery and lymphatic vessels, leading to fewer complications and lower recurrence rates compared to non-microsurgical techniques. Recurrence can still occur after surgery, although typically less frequently than with embolization. Summary box 86.4 summarizes the key points about varicoceles.
Okay, that's varicoceles covered. Let's move on to another common scrotal swelling, hydrocele. What's the definition here?
A hydrocele is defined as an abnormal collection of serous fluid within a part of the processus vaginalis, typically the tunica vaginalis, which is the sac-like layer surrounding the testes. Think of it as a fluid-filled sac.
Fluid around the testis.
Yes. The source distinguishes between acquired types, classifying them as primary, idiopathic, meaning no clear cause, or secondary, which result from an underlying issue like local injury, infection, neoplasm, or radiotherapy.
How common are hydroceles?
They are quite common, estimated to affect about 1% of adult men. Their origin relates to the embryological descent of the testes. In newborns, over 80% have a patent processus vaginalis, a connection between the abdominal cavity and the scrotum. But most of these close spontaneously within the first 18 months of life. If this process fails, it can lead to certain types of hydroceles or hernias.
Can you elaborate on the pathophysiology and the different structural types described in the source? How do they form?
Embryologically, as the testis descends from the abdomen, it pushes a pouch of peritoneum, the processus vaginalis, down into the scrotum. This pouch normally obliterates or closes off after the testis is in place. The tunica vaginalis is essentially the remaining non-obliterated portion of the processus vaginalis that surrounds the testes. Hydroceles form when fluid collects within this space. The source classifies them based on where the processus vaginalis has failed to close. 1. Communicating congenital hydrocele. Here, the processus vaginalis remains patent, maintaining a connection, usually small, between the peritoneal cavity and the tunica vaginalis in the scrotum. Peritoneal fluid can flow down into the scrotum, causing the hydrocele. These are often associated with indirect inguinal hernias.
So it's connected to the abdomen.
Yes. Then there's buzzers too, non-communicating vaginal hydrocele. In this type, the processus vaginalis is closed off, so there's no connection to the abdomen. The fluid collection within the tunica vaginalis happens because there's an imbalance between fluid production and absorption by the lining of the tunica, often related to disrupted lymphatic drainage. If there's no identifiable cause, like infection or injury, these are called primary hydroceles. Primary non-communicating hydrocele are the most common type globally.
Okay, sealed off but filling up.
Exactly. Then there's 3. Infantile hydrocele. This is a variation where the distal end of the processus vaginalis, near the testes, is closed, but the mid portion remains patent, and the proximal end is also open, connecting to the tunica vaginalis space around the testes.
A bit more complex.
And finally, 4. Hydrocele of the cord. In this specific type, both the distal end, near the testes, and the proximal end, near the internal ring of the processus vaginalis, close off, but a section in the middle along the spermatic cord remains patent and fills with fluid, like a cyst along the cord.
Got it. Which type is most common?
Non-communicating primary hydroceles are the most prevalent. Secondary hydroceles usually present in men over 40 and can appear acutely due to an underlying issue like inflammation, epididymo-orchitis, trauma, or crucially, a testicular tumor.
A tumor can cause one.
Yes, and the source includes a very important clinical caution here. If you are evaluating a scrotal swelling in a man and suspect a testicular tumor, do not perform diagnostic aspiration, meaning don't stick a needle in it to draw fluid.
Why not?
There's a theoretical risk of malignant needle tract implantation if the fluid is associated with a tumor. You could potentially spread cancer cells.
Right, definitely avoid that. How do you typically examine a scrotal swelling like a hydrocele to determine its nature? The source provides key questions to ask during the exam.
These are fundamental steps in evaluating any scrotal swelling and are invaluable for distinguishing between different causes. You examine the patient both standing and lying down. You are asking, 1. Can you get above the swelling? Using your fingers to palpate along the spermatic cord superior to the swelling. If you cannot get your fingers above the swelling to feel a normal spermatic cord entering it from above, it strongly suggests the swelling is extending upwards into the inguinal canal and is likely an inguinal hernia.
Okay.
With a hydrocele, you can typically feel the spermatic cord clearly above the fluid collection, demonstrating that the swelling is confined to the scrotum.
So hydrocele, you can get above it. Hernia, you can't.
Generally, yes. Second question. 2. Is the testis epididymis palpable, or are they enclosed? In a hydrocele, the fluid typically surrounds and encloses the testes and epididymis within the tunica vaginalis sac. This often makes the underlying testes difficult or impossible to feel distinctly on physical examination. An inguinal hernia, in contrast, is usually felt separately from the testes, which is typically palpable below the hernia.
So the testes is hidden inside the hydrocele fluid?
Often, yes. And 3. Does the swelling transilluminate? This is a classic test for fluid-filled structures. In a darkened room, holding a bright light source, like a flashlight, behind the scrotal swelling will cause a hydrocele, which is filled with relatively clear serous fluid to light up or transilluminate brightly. Solid masses or loops of bowel in a hernia generally do not transilluminate.
The light shines through the fluid. That makes sense.
Exactly. Getting above it and transillumination are key signs pointing towards a hydrocele.
An ultrasound is helpful here too, presumably.
Yes, ultrasound is a very useful adjunct in the assessment of almost all scrotal swellings. Figure 86.9b shows this. It provides a clear image of the fluid collection, confirms the diagnosis of hydrocele, and importantly, allows for definitive assessment of the underlying testes and epididymis, particularly when they are impalpable on physical examination.
Right, to see what's underneath.
Ultrasound is mandatory whenever the testes or epididymis cannot be clearly felt due to a scrotal swelling to rule out an underlying testicular abnormality like a tumor.
Tell me more about the typical primary hydrocele. Who gets these?
Primary hydroceles, figure 86.9a shows an example, are most common in middle-aged and older men, but can also occur in older children. They typically develop gradually and are usually painless, although they can grow quite large due to the accumulation of fluid, eventually becoming cumbersome or causing a dragging sensation due to weight. The source provides a cautionary note. Be vigilant if an acute hydrocele suddenly appears in a young man, as this presentation could be secondary to an underlying rapidly growing testicular tumor and requires urgent investigation, remembering the rule about not aspirating if tumor is suspected.
Right. Sudden onset in a young man needs a closer look. What about the congenital hydroceles seen in children? Do they behave differently?
In congenital hydroceles, due to the persistent processus vaginalis, the size can sometimes fluctuate. The swelling might appear smaller or disappear entirely when the child is lying down, as fluid drains back into the peritoneal cavity.
Ah, it comes and goes.
Sometimes. However, the opening is usually small, so it doesn't typically allow abdominal contents to herniate down like a true indirect hernia initially. If a child has bilateral scrotal swellings, you should also check for ascites, fluid in the abdominal cavity, as the congenital hydrocele is essentially an extension of the peritoneum.
And the hydrocele of the cord, how does that present?
A hydrocele of the cord presents as a smooth, oval swelling located along the spermatic cord, above and separate from the testes. It can sometimes be mistaken for an inguinal hernia because of its location.
Right.
However, unlike a hernia, it doesn't typically reduce back into the abdomen easily, and if you gently pull the testes downwards, the hydrocele of the cord swelling will move downwards with it and become less mobile, whereas a hernia would not.
Okay, that pulling test helps differentiate it.
The source also mentions a parallel condition in females, a hydrocele of the canal of Nuck, named after Anton Nuck. This is a cyst related to the round ligament, which is homologous to the spermatic cord, and is typically located partially within the inguinal canal.
Interesting. How are hydroceles treated? Are there medical or surgical options?
For congenital hydroceles in children that don't resolve spontaneously, treatment is surgical and involves ligating and dividing the patent processus vaginalis at the internal inguinal ring, essentially a herniotomy procedure, which prevents fluid from the abdomen from entering the scrotum.
Okay, surgery for the congenital ones that persist. What about adults?
For small asymptomatic hydroceles in adults, no treatment is needed. If the hydrocele is sizable, causing discomfort, or the patient finds it bothersome, surgical treatment is indicated. Established acquired hydroceles often develop quite thick walls over time, which influences the surgical approach.
What are the main surgical techniques for adult hydroceles described in the source?
The source describes several techniques. One, plication, such as Lord's operation, named after Peter Harrant Lord. This is a less invasive technique suitable for hydroceles with thin walls. The surgeon opens the sac but doesn't excise it. Instead, the redundant sac is folded and gathered up, or plicated, with a series of interrupted absorbable sutures, securing it behind the testes, figure 86.100A. This minimizes dissection and reduces the risk of bleeding and hematoma formation.
Folding it up, okay.
2. Aevesteris, such as Jaboulet's procedure, named after Mathieu Jaboulet. Here, the surgeon opens the hydrocele sac widely, then everts it, turning it inside out, and sutures the edge behind the testis. The testis is then placed back into the scrotum, with the everted sac positioned behind it, figure 86.lemb. The source notes there's a risk of hemorrhage from the cut edge of the sac with this method and suggests using overrunning stitches to control bleeding.
Turning it inside out.
Yes. Then there are non-surgical options, but with caveats. 3. Aspiration of the fluid. This is a simple procedure that can be done under local anesthetic, often for patients who are elderly or medically unfit for surgery. However, the source explicitly states that the fluid always reaccumulates, typically within about a week.
So it comes right back.
Always. Aspiration alone is not a definitive treatment and carries risks, including introducing infection or causing bleeding into the sac, leading to a painful hematocele.
Okay, not ideal long term.
4. Sclerosant injection. After aspirating the fluid, a sclerosing agent, like tetracycline or fibrin glue, can be injected into the empty sac to cause inflammation and scarring, hoping the sac walls stick together and prevent fluid reaccumulation. This can be effective in some cases, but is often painful and not as reliable as surgery, particularly for large or thick-walled hydroceles.
So surgery is generally the most definitive treatment for bothersome hydroceles, using either plication or everversion techniques. Summary box 86.5 outlines these key points. The source also briefly mentions hydroceles in specific geographical contexts, like tropical regions.
Yes, it highlights filarial hydroceles and chyloceles. These are extremely common in areas where lymphatic filariasis, caused by the parasitic worm Wuchereria bancrofti, named after Otto Wucher and Joseph Bancroft, is endemic. These hydroceles often follow repeated episodes of filarial epididymo-orchitis. A chylocele is a specific type where the fluid is milky or contains liquid fat, chyle, resulting from the rupture of dilated lymphatic vessels, a lymphatic varix, into the tunica vaginalis space. Long-standing filarial hydroceles can lead to dense adhesions and can eventually progress to filarial elephantiasis, causing massive thickening of the scrotal skin and tissues. Treatment in endemic areas often involves rest and aspiration, but for chronic cases, surgical excision of the thickened sac is necessary.
Fascinating how a parasitic infection can cause such a condition. Let's cover the last type of common swelling mentioned, cysts associated with the epididymis.
The source groups several types of cysts that originate near the epididymis. The key unifying features for these cysts, as summarized in Summary Box 86.6, are that they are typically located posterior to and separate from the testis itself, and they transilluminate, indicating they are fluid-filled.
By the testis, light shines through.
Exactly. Diagnosis is usually confirmed by ultrasound. Treatment is generally conservative, meaning observation, and no intervention unless the cyst becomes large, causes pain or discomfort, or is a cosmetic concern, in which case surgical excision might be considered.
Can you describe the most common type, epididymal cysts?
Epididymal cysts are very common. They are filled with clear fluid and can be multiple and of variable size. They essentially represent cystic degeneration within the epididymis itself. They are most often found in middle-aged men and can be bilateral.
What do they feel like?
On physical examination, they feel like a cluster of tense, smooth swellings located posterior to the testes, often described as feeling like a tiny bunch of grapes separate from the main testicular body.
Bunch of grapes.
They transilluminate brightly. Ultrasound, figure 86.11, confirms that they are multiloculated fluid collections within the epididymis. Aspiration of these cysts is generally ineffective because they are often multi-chambered. If they are causing significant discomfort or are very large, surgical excision is indicated. Single, large cysts can sometimes be excised individually, but recurrent or multiple cysts may require partial or even total epididymectomy.
Removing the epididymis.
Yes, removal of part or all of the epididymis. The source adds an important point for young men considering epididymectomy. They should be counseled that this procedure may interfere with sperm transport on the affected side, potentially impacting fertility.
Right, important consideration. And what about spermatoceles? How are they different?
A spermatocele is a specific type of cyst. It's a unilocular, single-chambered retention cyst that arises from a part of the sperm-conducting pathway within the head of the epididymis. It's typically located above and behind the upper pole of the testis. Spermatoceles tend to feel softer and more lax than typical epididymal cysts, but also transilluminate. A distinguishing feature is the fluid content. The fluid in a spermatocele contains spermatozoa and is often described as resembling barley water in appearance due to its milky or slightly cloudy nature.
Contains sperm. Looks like barley water.
Got it. Small spermatoceles are very common and of no clinical significance, so they can simply be ignored. Larger ones can be excised if they are bothersome.
That provides a clear breakdown of the common scrotal swellings, their characteristics, and management based on the source. Really useful distinctions. Let's move on to infections affecting the testes and epididymis, starting with epididymo-orchitis.
Epididymo-orchitis is a common infection defined as inflammation that starts in the epididymis, epididymitis, and often spreads to involve the testes as well, orchitis. It's typically caused by an infection.
How common is this, and who does it typically affect? Is it mostly older men?
Epididymitis, which is usually the initial phase, occurs in about 1 in 1,000 men annually. It's most prevalent in men aged 20 to 59 years, with a peak in the 20-39 age group, about 43% of cases, and a substantial incidence in the 40-59 age group, around 29%.
So younger and middle-aged adults mostly.
Yes. It's relatively rare in prepubertal boys, where, as we discussed, testicular torsion is a much more frequent cause of acute scrotal pain. Interestingly, the source states that when epididymitis does occur in prepubertal boys, nearly half, 47%, have underlying urogenital abnormalities.
Okay. How does the infection actually reach the epididymis? Does it come from the bloodstream or elsewhere?
The infection usually reaches the epididymis by ascending through the vas deferens from a primary infection in the urethra, prostate, or seminal vesicles.
Travels up the vas.
Exactly. The site provides a crucial general rule for identifying the likely cause based on age and risk factors. In young, sexually active men, epididymitis is most commonly caused by sexually transmitted infections, STIs, with chlamydia trachomatis now being the most frequent culprit, although Neisseria gonorrhea infection is also seen.
So younger men, STIs usually.
That's the general thought. In older men, especially those with bladder outflow obstruction, like from an enlarged prostate, or who have recently undergone urethral instrumentation or have an indwelling catheter, epididymitis is typically caused by organisms found in the urinary tract, often enteric bacteria like E. coli.
Older men and UTI bugs usually.
Right. The source suggests that high pressure in the prostatic urethra in these older men might lead to reflux of infected urine up the vasa deferentia into the epididymis. Blood-borne infection is less common and is suspected when there's no evidence of urinary infection. It's the only plausible mechanism for epididymal infection in men who have had a vasectomy.
How does the inflammation progress, and what are the potential complications? Can it damage the testes?
The infection typically starts in the tail of the epididymis, which is the most dependent part, and then spreads throughout the epididymis and often involves the adjacent testis, leading to orchitis. Potential complications of acute epididymo-orchitis include abscess formation within the epididymis or testis, testicular infarction or atrophy due to compromised blood supply from severe inflammation, chronic induration and inflammation leading to persistent pain, and potential long-term issues with fertility due to damage to the epididymis or testis.
Okay, so it can have lasting effects. What are the classic clinical features, and how is it investigated? How does the patient present?
Patients may or may not report preceding urinary or genital symptoms. The onset is often marked by a gradual ache in the groin or scrotum, which can progress to severe pain, often accompanied by fever and general malaise.
Gradual onset, unlike torsion.
Generally, yes, more gradual. On examination, the epididymis and typically the testes become swollen, firm, and exquisitely tender to touch. The scrotal wall rapidly becomes red, edematous, swollen with fluid, shiny, and may feel thickened and adherent to the underlying inflamed structures.
What tests are needed?
Investigation should include collecting a urethral swab and a urine sample for culture. Nucleic acid amplification testing, NAT, on a urine sample or a urethral swab is highly sensitive for detecting chlamydial and gonococcal urethritis, which are common causes in younger men.
Right, check for STIs.
Urinalysis often reveals the presence of leukocytes, white blood cells, and urine culture may identify a specific bacterial pathogen, especially in older men. Ultrasound is a valuable tool in the initial assessment. It can help confirm the diagnosis by showing an enlarged heterogeneous epididymis and testes, figure 86.12a, and demonstrating increased blood flow on Doppler imaging, which indicates inflammation, figure 86.12b. It's also important for identifying potential complications like abscess formation.
Again, in adolescence, this must be differentiated from testicular torsion, which is a surgical emergency. That seems like a recurring theme.
Absolutely critical. As the source emphasizes, if there is any clinical doubt between epididymo-orchitis and testicular torsion, prompt surgical scrotal exploration is mandatory to rule out torsion, given its time-sensitive nature. The consequences of missing torsion are far more severe than surgically exploring for epididymo-orchitis. You cannot afford to wait if torsion is possible.
How is epididymo-orchitis treated then once you're confident it's infection?
Treatment involves initiating presumptive antibiotic therapy at the time of the initial clinical visit without waiting for all laboratory results.
Start treatment right away.
Yes. This prompt treatment is crucial for symptom improvement, preventing transmission in STI cases, and minimizing complications like infertility and chronic pain. The choice of antibiotics is based on the most likely cause, which is guided by the patient's age and risk factors. The source provides sample regimens adapted from guidelines like the 2021 CDC STI treatment guidelines, noting that local antibiotic resistance patterns should always be considered.
What are some typical antibiotic choices?
For suspected sexually transmitted causes in young men, a typical regimen is a single intramuscular dose of ceftriaxone to cover gonorrhea, combined with a 10-day course of oral doxycycline to cover chlamydia.
Okay, covering both common STIs.
If the patient practices insertive anal sex, the risk includes both STIs and enteric organisms, so a regimen covering both is needed, such as ceftriaxone plus 10 days of levofloxacin. For likely enteric organisms, common in older men with urinary issues, a 10-day course of levofloxacin or another suitable fluoroquinolone is often used initially.
And you need to treat partners if it's an STI.
Absolutely. If an STI is suspected or confirmed, contact tracing and treatment of sexual partners are essential to prevent reinfection and further spread. In older men with documented urinary tract infection, isolating the specific organism from the urine culture allows for tailoring the antibiotic choice. Intravenous antibiotics may be necessary if there are signs of systemic sepsis.
What about other measures? Pain relief.
Yes. Local measures like scrotal support, like supportive underwear or an athletic supporter, to reduce swelling and pain, along with appropriate analgesia painkillers, are also important components of management.
And the duration of antibiotics, how long?
The source recommends a course of oral antibiotics for at least 10 days or until the inflammation has subsided completely to ensure adequate treatment and reduce the risk of chronic inflammation. If an abscess is detected on ultrasound, surgical or percutaneous drainage is usually required in addition to antibiotics. Summary Box 86.7 highlights these key aspects of epididymo-orchitis management.
The source also mentions chronic forms of epididymitis. What happens there?
Yes, chronic non-tuberculous epididymitis can occur when acute inflammation fails to resolve completely or recurs. Patients experience persistent or intermittent discomfort and have a thickened, tender epididymis on examination.
Is it hard to treat?
It can be challenging. Treatment often involves prolonged courses of antibiotics like quinolones or doxycycline and anti-inflammatory medications for 4 to 6 weeks. Surgical options such as epidydymectomy or even orchidectomy may be considered if conservative measures fail to alleviate symptoms. However, the source provides a caution. Up to 50% of patients continue to experience pain even after surgery, highlighting the difficulty in managing chronic cases.
50% still have pain after surgery. Ouch. And there's a specific section on tuberculous epididymo-orchitis. Is that still common?
It's less common in many Western countries now, but is still a significant consideration globally, especially in areas where tuberculosis is prevalent. It typically has a more insidious onset compared to acute bacterial epididymo-orchitis. It doesn't usually come on suddenly.
How does the TB infection get there?
The infection is usually thought to begin at the lower pole of the epididymis, often representing retrograde spread from a tuberculous focus elsewhere in the genitourinary system, such as the seminal vesicles or prostate.
What are the clinical features that suggest tuberculous epididymo-orchitis? How does it feel?
Clinically, it often presents as a firm, somewhat uncomfortable, but not acutely painful swelling that initially affects the lower pole of the epididymis. As it progresses, the entire epididymis becomes firm and has a hard, irregular, or craggy feel on palpation.
Craggy, like a bumpy.
Yes, irregular and hard, while the testis itself may initially feel normal. About 30% of cases develop a lax secondary hydroceles. A characteristic finding, if present, is palpable induration or beading of the vas deferens above the epididymis.
Beading, like little bumps along the vase.
Exactly, representing subepithelial tubercles along the vas. The seminal vesicles, if involved, may also feel indurated and swollen on rectal examination. In neglected cases, a tuberculous cold abscess can form, which may eventually rupture and discharge pus through the scrotal skin, forming a chronic sinus. The testis body itself may remain uninvolved for a considerable time, sometimes years.
Wow. Is it often linked to TB elsewhere?
Importantly, yes. About 2/3 of patients with tuberculous epididymo-orchitis have evidence of associated renal tuberculosis or previous TB disease elsewhere in the body, although the patients themselves may otherwise appear healthy.
How is this condition investigated and treated?
Investigation should include repeated examinations of early morning urine and semen samples for tubercle bacilli using microscopy, culture, and increasingly PCR. Imaging of the chest and upper urinary tract, kidneys, ureters, bladder, is also important to look for other sites of TB disease. Ultrasound of the scrotum will typically show a thickened, sometimes heterogeneous epididymis.
And treatment, is it just TB drugs?
Treatment involves standard anti-tuberculous drug therapy, often in combination with drugs targeting the primary TB focus if identified elsewhere. While a genitourinary disease may resolve with systemic treatment, drug effectiveness can be less certain in genital TB compared to urinary TB. If there is no significant improvement in the local swelling after 2 months of chemotherapy, surgical intervention, typically epidydymectomy or even orchidectomy, may be advisable. Crucially, a full course of anti-tuberculous chemotherapy, usually lasting several months, must be completed even if there is no detectable TB disease elsewhere in the body to prevent recurrence and transmission.
The source also mentions a couple of other less common forms of orchitis inflammation of the testis itself.
Yes, it briefly touches on mumps orchitis, which is actually the most common form of orchitis overall, though mumps itself is less common now due to vaccination. It develops as a complication in 20-30% of post-pubertal males infected with the mumps virus, typically appearing as the parotid gland swelling begins to subside. The diagnosis is supported by a history of mumps and serological testing for mumps IgM antibodies. The main complication of mumps orchitis is testicular atrophy.
Shrinking of the testes.
Yes, which can occur unilaterally or bilaterally, potentially leading to infertility if both tests are significantly affected. Partial atrophy is also associated with persistent testicular pain.
Okay, and the other one?
Finally, syphilitic orchitis is mentioned, although it is uncommon in the modern era. It can occur in congenital syphilis, often presenting as bilateral diffuse orchitis. In adult-acquired syphilis, it can manifest as interstitial fibrosis, leading to painless destruction and hardening of the testes. More rarely, it can present as a gumma of the testes, which is a specific type of syphilitic liction forming a solitary, slowly growing, painless swelling that can be clinically difficult to distinguish from a testicular neoplasm without surgical exploration. Diagnosis is confirmed by serological tests for syphilis.
That covers the spectrum of infections clearly. Now, let's move to what is often the most feared diagnosis when dealing with scrotal issues: tumors of the testes and epididymis.
Absolutely. Testicular cancer is a particularly significant topic because while it accounts for only about 1.5% of all male neoplasms, it is the most common malignancy in young men, specifically in the age range of 15 to 35 years.
The most common cancer in young men. That's striking.
It is. And the incidence has unfortunately been increasing in Western societies over the past 30 years, with figures now around 3 to 10 new cases per 100,000 males annually.
What are the main types of testicular tumors? Is it mostly one kind?
The predominant histology by far, accounting for 90-95% of cases in adults, are germ cell tumors, GCTs. These arise from the cells that would normally develop into sperm.
Okay, GCTs are the main players.
Right. Other rare types making up the remaining cases include sex cord stromal tumors, originating from supporting tissues in the testes, lymphoma, and other miscellaneous tumors.
Do the different types of germ cell tumors affect different age groups within that young adult range?
Yes, there's a slight difference in peak incidence within the GCTs. Seminomas tend to peak in the fourth decade of life, 30s, whereas non-seminomatous germ cell tumors, NSGCTs, have their peak incidence slightly earlier in the third decade, 20s.
Seminoma and non-seminoma. Got it. Are there any known genetic markers or risk factors for developing these tumors? We touched on cryptorchidism earlier.
Yes. The source mentions a specific genetic marker, an isochromosome 12p, I12p, which is considered pathognomonic, meaning uniquely characteristic for all types of adult GCTs and their precursor lesion, germ cell neoplasia in situ, GCNIS.
Right.
Epidemiological risk factors are well established and important. As we discussed earlier, cryptorchidism is a major risk factor, significantly increasing the likelihood of developing cancer in that testis. Other risk factors include male factor infertility, including men with genetic conditions like Klinefelter syndrome, named after Harry Fitch Klinefelter Jr., having a familial history of testicular cancer in a first-degree relative, father or brother, and having a previous testicular tumor or GCNIS in the contralateral testis.
Let's break down the main types of GCTs described in this source, starting with seminoma. What characterizes that one?
Seminoma is the single most common type of testicular germ cell tumor, accounting for about 50% of all GCTs. Macroscopically, meaning to the naked eye when the testis is sectioned, it typically has a homogeneous, pinkish cream-cut surface and appears to compress the surrounding normal testicular tissue. Figure 86.23 shows this.
Looks fairly uniform.
Yes. Histologically, under the microscope, seminomas are characterized by sheets of relatively uniform, oval-shaped cells with clear cytoplasm and large, rounded nuclei containing prominent nucleoli, often resembling spermatocytes. The cells are separated by a fine fibrous stroma, and lymphocytic infiltration within the tumor is common and often suggests a favorable host immune response associated with a better prognosis. Seminomas are rarely seen in childhood, in very young adults, or in men over 70 years of age.
How do seminomas typically spread? Where do they go first?
Seminomas mainly metastasize via the lymphatic system. Figure 86.14 illustrates the pathways. The primary lymphatic drainage of the testes follows the path of the gonadal vessels, leading directly to the para-aortic lymph nodes located in the retroperitoneum near the origin of the testicular artery from the aorta.
Okay, up to the back near the kidneys.
Exactly. Lymphatic spread is typically orderly, moving up to these regional nodes. Contralateral para-aortic nodes can sometimes become involved later. Spread to the inguinal lymph nodes in the groin occurs only if the tumor has invaded and extended through the tunica albuginea and involved the scrotal skin, as the scrotum has a separate lymphatic drainage pathway to the inguinal nodes. Hematogenous spread, via the bloodstream, to distant organs is uncommon in seminoma, particularly in early stages. The initial investigation for any suspected testicular tumor, including seminoma, is always ultrasound. Figure 86.15 shows a small seminoma.
What about the non-seminomatous germ cell tumors, NSGCTs? These sound more complex, maybe more varied.
They can be, yes, as NSGCTs comprise several different histological types, and often a single tumor will contain a mixture of these different cell types. Embryonal carcinoma. These are highly malignant and tend to be more aggressive than pure seminoma. They can occasionally invade the spermatic cord structures. On ultrasound, they might appear as a larger, less homogeneous mass. Figure 86.16 illustrates a large one occupying most of the testes.
More aggressive, okay.
Yolk sac tumor. Histologically, these tumors have a characteristic loose stromal pattern. They can resemble embryonal carcinoma, but sometimes show differentiation towards liver or intestinal tissue. Yolk sac tumors are particularly important because they are the single most common malignant tumor type seen in children, but are usually only found as part of a mixed GCT in adults.
Common in kids, part of a mix in adults.
Right. And a key feature is that yolk sac tumors characteristically produce alpha-fetoprotein, AFP, a protein that can be measured in the blood serum and serves as a valuable tumor marker.
AFP marker for yolk sac. Got it.
Teratoma. Teratomas are derived from tissues of all three embryonic germ layers, ectoderm, endoderm, and mesoderm. This means they can contain a bizarre mix of tissues, such as skin, hair, teeth, cartilage, bone, or gut epithelium. Basically, bits of everything. Figure 86.17a shows a specimen with varied areas. Figure 86.16b shows variable appearance on ultrasound.
Wow, quite a mix.
The old distinction between mature, well-differentiated tissues and immature teratomas has largely been abandoned in the context of the testis because the source emphasizes that all teratomas occurring in adult testes have the potential to metastasize, unlike teratomas in other parts of the body.
So even mature ones can spread in adults.
Correct. Choriocarcinoma. This is a highly aggressive component of GCTs. It's found as part of a mixed GCT in about 25% of adult testicular tumors, but is rarely the sole component. It is almost never seen in childhood. Choriocarcinoma characteristically produces high levels of human chorionic gonadotropin, HCG, a hormone also detectable in the blood serum, which serves as another important tumor marker.
HCG marker for choriocarcinoma.
Yes, and choriocarcinoma is known for its rapid growth and ability to metastasize early via both the lymphatic system and, notably, the bloodstream, leading to widespread distant metastases.
Spreads quickly through blood, too.
Yeah.
Nasty. The source also mentions spermatocytic seminoma as a distinct entity. How is that different?
Yes, this is now considered a separate type of germ cell tumor, accounting for maybe 1–2% of all GCTs. It's unique in that it occurs almost exclusively in adult men, typically over the age of 50.
Older men, unlike the others.
Right, and in stark contrast to classical seminoma and NSGCTs, it rarely metastasizes. For this reason, radical orchidectomy is often the only treatment required. The source does note, however, that sarcomatous transformation has been reported if these tumors are left untreated for a very long time.
What about the rarer sex cord stromal tumors? Where do they come from?
These tumors arise from the supporting tissues of the testes, Sertoli cells and Leydig cells. They are rare, making up less than 5% of testicular neoplasms. Leydig cell tumors. These are the most common type within this group, representing 1–3% of adult testicular tumors and about 3% in children. They are seen with increased frequency, around 8%, in men with Klinefelter syndrome.
Okay.
On gross examination, they are usually well demarcated, solid, and have a yellow-tan appearance, typically smaller than 5 centimeters. About 30% may show areas of hemorrhage and necrosis. The vast majority, 90%, are benign. Malignant transformation occurs in about 10% and is associated with features like larger size, 5 centimeter, cellular atypia, increased cellular proliferation, necrosis, invasion of blood vessels, and DNA aneuploidy. Some Leydig cell tumors can produce hormones, androgens, or estrogens, leading to precocious puberty in children or gynecomastia in adults.
So mostly benign, but can be malignant.
Sertoli cell tumors. These are even rarer, less than 1% of testicular tumors. They have a mean age of presentation around 45 years, but sporadic cases can occur under the age of 20. They are rarely associated with genetic syndromes like androgen insensitivity or Peutz-Jeghers syndrome, named after John Peutz and Harold Jeghers. Malignancy rates range from 10–22%.
Also mostly benign.
A bit higher risk of malignancy than Leydig cell tumors, but still relatively low overall. Granulosa cell tumors, extremely rare in adults, but the juvenile type accounts for about 6% of testis tumors seen in childhood.
And there's also mention of a mixed type of tumor involving both germ cells and sex cord cells, gonadoblastoma.
Yes, the gonadoblastoma. This is a distinct tumor containing a mixture of 2 cell types. Large germinal cells resembling seminoma and smaller cells resembling granulosa or Sertoli cells, sometimes with associated Leydig or luteinized cells. Gonadoblastomas are strongly associated with underlying gonadal dysgenesis.
Problems with gonad development.
Exactly. They are most commonly seen in individuals with mixed gonadal dysgenesis or Swyer syndrome, particularly those with a Y chromosome or Y chromosome material. There is a high risk, 15 to 25%, of developing a gonadoblastoma in dysgenetic gonads. These tumors are rarely seen in phenotypical and genotypical males with normally descended testes.
Let's move to the clinical features of testicular tumors. How do patients typically present? What should someone look out for?
The classic presentation, and most common, is a painless testicular lump or swelling.
Painless lump, that's the key.
Yes. If the tumor becomes quite large, patients may describe a sensation of heaviness in the scrotum. While pain is uncommon, some patients do experience discomfort or a dull ache. Sometimes a minor trauma to the scrotum simply draws the patient's attention to an already existing swelling. The presentation can occasionally mimic other conditions like epididymo-orchitis with tenderness and swelling. More rarely, acute severe pain and rapid enlargement can occur if there's hemorrhage within the tumor, which can even be mistaken for testicular torsion.
So a painless lump is the red flag to look for, but it can sometimes be painful or mimic other things.
Correct. Any firm, painless lump within the testes is highly suspicious for malignancy until proven otherwise. It's crucial to emphasize self-examination to detect these early.
And sometimes the first symptoms aren't even from the testes itself, they come from spread.
Correct. In a small percentage of cases, the primary tumor in the testis may be relatively small and go unnoticed by the patient, while the first symptoms arise from metastatic disease. For example, enlarged para-aortic lymph nodes in the abdomen might cause back pain or flank pain.
Okay.
Spread to the lungs, particularly common with NSGCTs and choriocarcinoma, can lead to symptoms like chest pain, shortness of breath, or coughing up blood in more advanced stages. The primary tumor in the testis might then only be detected during the metastatic workup, perhaps on a screening ultrasound. Figure 86.15 shows how even a small seminoma might be seen on ultrasound.
What does the physical examination reveal when a testicular tumor is present? What do you feel?
On physical examination, the key finding is typically a firm, solid mass located within the substance of the testes. Unlike conditions like epididymitis or hydrocele, you can usually feel that the abnormality is intrinsic to the testicle itself.
Part of the testes, not just around it.
Exactly. A secondary hydrocele may be present, making it more challenging to accurately palpate the underlying testes and epididymis. About 5% of men with testicular tumors, predominantly those with NSGCTs, especially if they produce HCG, may present with gynecomastia, enlargement of breast tissue. Clinical evidence of metastatic disease is relatively uncommon at the initial presentation and is usually identified during the formal staging process. Tumors are bilateral at diagnosis in only 1–2% of cases.
How are testicular tumors investigated and staged after a suspicious finding? What are the crucial tests?
The diagnosis is typically strongly suspected based on clinical examination and confirmed with an ultrasound scan of the scrotum. Figure 86.66 clearly shows a tumor. Ultrasound is mandatory in all suspected cases and should also be performed on the contralateral testes to check for synchronous tumors or other abnormalities.
Ultrasound first. Then what?
Once a tumor is suspected based on ultrasound, staging is absolutely essential to determine the extent of the disease and plan appropriate treatment. Tumor markers are critical. Blood is taken before surgical removal of the testes, radical orchidectomy, to measure serum levels of key tumor markers. These markers are elevated in about 50% of testicular cancer patients, but their presence and levels provide vital information for diagnosis, prognosis, and monitoring treatment response.
Which markers are measured?
AFP, alpha-fetoprotein. This marker is raised in 50–70% of men with NSGCTs, particularly yolk sac tumors and embryonal carcinomas. It is never elevated in pure seminoma. The mean serum half-life of AFP is relatively long, about 5–7 days.
Okay, AFP for NSGCT, not seminoma.
HCG, human chorionic gonadotropin. This hormone is raised in 40–60% of men with NSGCTs, especially choriocarcinoma and embryonal carcinoma components, and in about 30% of seminomas, often those with syncytiotrophoblasts cells. The mean serum half-life of HCG is much shorter, only 2–3 days.
HCG for NSGCT and sometimes seminoma.
LDH, lactate dehydrogenase. This enzyme is less specific than AFP or HCG, but is often elevated in testicular cancer. It's expressed from a gene on chromosome 12p, which is often amplified in testicular cancer cells. Elevated LDH levels are associated with high tumor burden, particularly in seminoma, and can indicate recurrence in NSGCTs.
How are these markers used after surgery?
The half-lives of AFP and HCG are particularly useful after radical orchidectomy. If the tumor produced these markers, their levels should fall in the blood at the expected rate based on their half-life if all the tumor tissue has been successfully removed. Persistence, or a slower than expected decline, indicates residual metastatic disease. They help monitor treatment success.
Very clever. And for imaging to detect metastasis, what scans are used?
Imaging is crucial for detecting metastasis. A chest radiograph can reveal lung metastases, which can appear as classical cannonball lesions, figure 86.1a. However, the most useful and central imaging test for staging is a CT scan of the chest, abdomen, and pelvis.
CT scan is the workhorse.
Yes. This allows visualization of the main sites of potential lymphatic spread, para-aortic nodes, figure 86.1ab shows a large one, and distant hematogenous spread, lungs, liver, etc. CT scanning is used to stage the disease according to systems like the TNM classification, 8th edition, and is essential for both initial staging and monitoring response to treatment. Summary box 86.8 encapsulates these important points on investigation and staging.
Let's discuss the treatment for testicular tumors. What's the initial step, and how is treatment decided based on stage and histology? This seems like an area with good outcomes now.
Yes, outcomes are generally excellent. Before any potentially fertility-impacting treatments like surgery or chemotherapy, the source strongly recommends offering all men semen analysis and sperm banking, as subsequent treatment can cause irreversible infertility.
Sperm banking first. Critical point.
Absolutely. The initial surgical step for a suspected testicular tumor is a radical orchidectomy, which is the surgical removal of the testes and spermatic cord. This is performed via an inguinal incision in the groin, not directly through the scrotum.
Through the groin, not the scrotum. Why?
The surgeon exposes the spermatic cord, places a soft clamp across it high up near the internal inguinal ring to minimize the theoretical risk of disseminating malignant cells during manipulation of the testes. And if the tumor is confirmed, the cord is double transfixed, tied off securely in two places, and divided at the level of the internal ring before the testis is removed. Removing the cord high in the groin, rather than through the scrotum, is important because it removes the primary lymphatic drainage pathway to the retroperitoneal nodes and avoids potentially involving the scrotal lymphatics, which drain to the inguinal nodes and would change the pattern of spread.
Got it. Preserve the lymphatic pathways.
After the orchidectomy, the testis is sent for histological analysis to determine the exact type of tumor. Treatment then depends heavily on the tumor histology, seminoma versus NSGCT, and the stage of the disease. The source notes that treatment is usually highly successful, even for advanced disease, due to the remarkable sensitivity of these tumors to chemotherapy and, for seminomas, radiotherapy.
Okay. How are they staged?
Patients are staged according to systems like the TNM classification into Stage I, non-metastatic disease confined to the testis, Stage II, metastasis to regional lymph nodes, typically periaortic, and Stage III, distant metastasis or nodal metastasis with elevated markers. At diagnosis, a large proportion of cases are Stage I, maybe 75-80% of seminomas, and 55-64% of NSGCTs.
So for non-metastatic disease, Stage I, what are the management strategies outlined in the source? Is surgery enough?
It depends. The source discusses strategies for Stage I disease, often adapted from guidelines like those from the European Association of Urology. For Stage I seminoma, CSI, it's known that about 15% of these patients actually have microscopic subclinical retroperitoneal metastases that aren't visible on scans but will lead to relapse if treated with orchidectomy alone.
So surgery alone isn't always enough, even if scans are clear.
Correct. Management options include surveillance. This is a valid option, particularly for patients with low-risk features, tumor size less than 4 centimeters, no invasion of the testes. Recurrence rates on surveillance are around 6% for these low-risk cases, but overall cancer-specific survival with effective salvage chemotherapy upon relapse is over 95%. The drawback is the need for intensive follow-up with regular imaging.
Watchful waiting, basically.
Yes. Adjuvant chemotherapy. A single course of adjuvant carboplatin chemotherapy is an alternative. Studies comparing one course of carboplatin to radiotherapy have shown no significant difference in recurrence rate, time to recurrence, or survival at a median of 4 years follow-up.
One shot of chemo.
Adjuvant radiotherapy. Seminomas are highly radiosensitive. Radiotherapy to the periaortic lymph node field, or sometimes periaortic plus ipsilateral iliac nodes, significantly reduces the relapse rate to only 1-3%. While highly effective at preventing recurrence, a concern with radiotherapy is the very low but real long-term risk of secondary malignancies later in life.
So for Stage I seminoma, there are a few options. balancing risk of relapse against treatment side effects and follow-up burden. What about stage I NSGCT? Is it different?
Stage I NSGCT is different, yes. Up to 50% of these patients have subclinical metastases that will manifest as relapse if only observed.
50%. Much higher risk of hidden spread.
Exactly. Management options include surveillance. Surveillance is an option, but given the much higher relapse rate, 14 to 48% within 2 years, it is primarily offered to compliant patients who are carefully risk stratified, for example, based on the presence of lymphovascular invasion, and fully understand the higher chance of relapse and the need for subsequent salvage chemotherapy.
Higher risk surveillance.
Adjuvant chemotherapy. This is now a widely recommended strategy for stage I NSGCT to reduce the high relapse rate. A single cycle of combination chemotherapy using bleomycin, etoposide, and cisplatin, BEP, is standard. This significantly reduces the recurrence rate to around 3%. The concern, as with radiotherapy for seminoma, relates to very long-term side effects, particularly potential cardiovascular risks, which are still being fully assessed.
One cycle of BEP seems common now.
Retroperitoneal lymph node dissection, RPLND. This surgery involves removing the lymph nodes in the retroperitoneum. Its role as primary management for stage I NSGCT has decreased somewhat with the advent of effective adjuvant chemotherapy. A study comparing one cycle of adjuvant BEP to RPLND showed a significantly higher 2-year recurrence-free survival rate for chemotherapy, 99.5%, compared to RPLND alone, 91%.
So chemotherapy has become a preferred adjuvant strategy, especially for stage I NSGCT, to minimize the risk of relapse. What about patients who present with metastatic disease, stages 2 and 3? What's the approach?
For patients with metastatic testicular cancer, the primary treatment modality is systemic chemotherapy. For metastatic seminoma, even early stage 2 disease, chemotherapy, typically 3 cycles of BEP or 4 cycles of etoposide and cisplatin EP, is now often preferred over radiotherapy due to its effectiveness and lower risk of long-term cardiovascular and secondary malignancy issues compared to extensive radiotherapy fields. Both are effective, but there's a trend favoring chemotherapy, especially for stage IIB disease, bulky nodal disease.
Chemo preferred for metastatic seminoma too, and NSGCT.
For advanced NSGCTs, stages 2 and 3, the initial treatment is chemotherapy, primarily using BEP regimens in virtually all cases except for a specific situation. Postpubertal teratoma that is metastatic to lymph nodes but without any elevated tumor markers, AFP or HCG.
Ah, the marker-negative teratoma mets.
Exactly. That specific scenario is typically managed surgically with a primary RPLND rather than chemotherapy.
How are the rarer sex cord stromal tumors managed? Is it the same?
No, it's different. Most sex cord stromal tumors are benign, around 80%. For small lesions, particularly if the diagnosis is suspected preoperatively, conservative, organ-sparing surgery, just removing the tumor nodule with a margin, can be considered. However, larger tumors typically require radical orchidectomy. For the rare malignant forms, which are relatively resistant to standard chemotherapy and radiotherapy used for GCTs, multimodality treatment involving surgery and sometimes chemotherapy or targeted therapies is needed.
Overall, what's the prognosis for testicular cancer? It sounds like treatment is very effective now.
The prognosis for testicular cancer is generally excellent, even for advanced cases, when treated appropriately with combination chemotherapy in a specialized cancer center. The high sensitivity of these tumors to platinum-based chemotherapy is a key factor in their curability. Summary box 86.9 reinforces the importance of histology, tumor markers, and CT scanning for staging and guiding these highly effective treatments.
The source also highlights that testicular tumors in children are distinct from those in adults. How so?
Yes, this is an important point. While germ cell tumors are the most common type in children, 60-75% of cases, the specific histological distribution is different from adults, where it's 95% GCTs. The single most common malignant testicular tumor in children is the yolk sac tumor, which is very rare as a pure tumor type in adults.
Yolk sac tumor dominates in kids.
Yes. Surgical treatment in children usually involves radical orchidectomy, especially if the AFP level is elevated in a child over 1 year old, as this is highly suggestive of a malignant yolk sac tumor. However, if AFP is normal in a child, it strongly suggests a benign tumor type, such as an epidermoid cyst. In these cases, testis-sparing surgery, removing only the mass rather than the entire testis, can often be considered to preserve testicular function.
Testis-sparing is possible if AFP is normal. Good to know. And finally, tumors of the epididymis, sometimes called paratesticular tumors because they are outside the testis itself. Are these common?
These are significantly rarer than testicular tumors, accounting for only about 5% of all intrascrotal tumors. Fortunately, the vast majority, 70 to 80%, are benign. About 30% of paratesticular tumors actually arise from the epididymis.
So, Rare and mostly benign.
Yes. These tumors typically originate from soft tissue or mesothelial tissue. The most common benign types are cystadenomas, papillary tumors, and adenomatoid tumors. Malignant tumors of the epididymis, such as sarcomas or secondary metastases from other cancers, are exceedingly rare. Any solid mass arising from the epididymis still warrants investigation, typically with ultrasound, but they are far less likely to be malignant than a solid mass within the testis itself.
That provides a comprehensive overview of testicular and peritesticular tumors, covering histology, markers, staging, and treatment strategies with impressive detail. A lot to take in, but crucial for mastery. Let's move to specific conditions affecting the scrotum itself, starting with a truly severe one mentioned in the text, Fournier's gangrene. That sounds ominous.
It is. Fournier's gangrene is described as an uncommon but life-threatening condition. It's a particularly aggressive form of necrotizing fasciitis.
Flesh-eating bacteria.
Essentially, yes, a rapidly spreading infection that destroys the soft tissues. It specifically affects the perineum, external genitalia, including the scrotum, and perianal region. Its hallmark is the rapid onset of gangrene, meaning tissue death, which can quickly lead to exposure of the underlying structures, like the testes.
What causes this severe infection? Does it just appear?
It can sometimes stem from a local septic source in the testes, epididymis, or the perianal region, like an abscess. However, the source notes that in over half of cases, there is no obvious preceding cause or injury identified.
No clear trigger often.
Right. It can occasionally follow seemingly minor insults or procedures in the perineal area, such as a bruise, a scratch, urethral dilation, injections for hemorrhoids, or drainage of a periurethral abscess. A critical point highlighted by the source is that many patients who develop Fournier's gangrene have underlying concurrent illnesses that significantly compromise their immune defenses and ability to fight infection. The most notable of these risk factors are diabetes, mellitus, and alcoholism.
Diabetes and alcoholism are major risk factors.
Yes. Other conditions like malnutrition, obesity, and immunosuppression can also increase risk.
How does it progress so rapidly and destructively? What's happening biologically?
It's a polymicrobial infection, meaning it's caused by a mixture of different bacteria, typically involving both aerobic oxygen-using and anaerobic non-oxygen-using organisms that work together synergistically.
A gang of bacteria working together.
You could say that. This mixed infection causes a fulminating or very rapidly developing and severe inflammation of the subcutaneous tissues, the layer just beneath the skin. A key pathological process is an obliterative arteritis, which is inflammation and blockage of the small arteries supplying the scrotal skin and subcutaneous tissue. This cuts off the blood supply, leading to rapid tissue death and gangrene. The infection and necrosis can spread incredibly quickly along the fascial planes of the penis, perineum, and abdominal wall, sometimes extending quite far from the initial site.
What are the clinical features? How would someone know they have this? Does it start subtly?
The hallmark clinical feature is intense pain and tenderness in the affected area of the genitalia or perineum. The source details the typical progression, which can occur over just 2 to 7 days. It might start with prodromal symptoms like fever and lethargy.
Feeling unwell first.
Yes. This is followed by the onset of intense genital pain, often with overlying skin edema, swelling, and sometimes itching. The pain increases rapidly, accompanied by progressive erythema, redness of the skin. As the tissue starts to die, the skin develops a dusky or purplish appearance, and you might feel a subcutaneous crepitation, a crackling sensation under the skin caused by gas produced by certain bacteria.
Crackling skin.
Yes. Finally, there's the appearance of obvious gangrene of part of the genitalia, often with a foul-smelling, purulent discharge. The source notes that in the early stages, the patient's pain can be out of proportion to the physical findings.
Pain worse than it looks.
Exactly, meaning they report excruciating pain even if the skin changes are not yet dramatic. Later, as the nerve tissue necroses and dies, the pain might actually subside, which is a sign of very advanced disease. Systemic effects are variable, ranging from localized tenderness in milder cases to massive septic shock and severe, rapidly spreading infections, with the severity generally proportional to the extent of tissue necrosis.
This sounds like an absolute medical and surgical emergency, requiring immediate intervention. No waiting around.
It is unequivocally a surgical emergency. Management must be immediate and aggressive. Initial steps involve aggressive intravenous fluid resuscitation to combat shock and starting broad-spectrum intravenous antibiotics to target the likely mixed aerobic and anaerobic bacteria.
Fluids and strong antibiotics.
Yes. However, the most critical intervention is urgent, wide surgical excision or debridement of all dead and infected tissue. The source stresses that the extent of internal necrosis is typically much greater than what is apparent from the external appearance of the skin. Therefore, extensive debridement is necessary to remove all non-viable tissue and halt the spread of the infection. You have to cut out everything that's dead.
Aggressive surgery is key.
Absolutely. Depending on the extent of the gangrene and associated infection, temporary urinary diversion with a catheter or suprapubic tube, or even fecal diversion with a colostomy may be necessary. Supportive care is absolutely essential in the intensive care setting, as these patients are often severely septic and critically ill. Early review of the surgical wounds, sometimes daily, is crucial to ensure all dead tissue has been successfully removed and to perform further debridement if needed. Vacuum-assisted dressings can be helpful for wound management. If the patient survives the acute life-threatening phase, extensive skin grafting is often necessary later to cover the resulting tissue defects.
What is the prognosis for Fournier's gangrene? Does everyone survive?
Unfortunately, no. Despite aggressive modern medical and surgical therapy, Fournier's gangrene remains a disease with a high mortality rate. The source reports mortality rates as high as 50%, highlighting the severe and dangerous nature of this infection. Summary box 86.1 underscores the urgency and necessity of early, aggressive surgical debridement and broad-spectrum antibiotics, linking the condition to Jean-Alfred Fournier, the syphilologist who first described it in the late 19th century.
50% mortality even with modern treatment. Grim. There's also a mention of carcinoma of the scrotum in the source. Is that common?
Carcinoma of the scrotum is a rare form of skin cancer, but it holds historical significance. It was famously described by Percival Pott in 1775 as chimney sweeps cancer, making it the first reported occupational cancer.
Chimney sweeps.
Yes. Historically, it was also associated with workers exposed to oil and coal products, with polycyclic aromatic hydrocarbons being proposed as etiological factors. In modern times, while the link to these specific occupational exposures is much less common due to changes in practice, occasional cases still occur, often without an obvious identifiable cause.
How does it typically present? What does it look like?
It usually starts as a chronic, non-healing lesion on the scrotal skin, often appearing as a wart or an ulcer. Figure 86.2 says, for an example. Over time, it grows and can invade the underlying tissues, potentially involving the testis itself in later stages.
How is it treated?
Treatment typically involves surgical excision of the tumor with a margin of healthy surrounding skin to ensure all cancer cells are removed. Because the scrotum's lymphatic drainage is to the inguinal lymph nodes, the management of the inguinal nodes is critically important and parallels the approach taken for penile cancer. This involves assessing the inguinal nodes for metastasis, often using techniques like sentinel node biopsies, identifying and sampling the first draining lymph node. Or, if nodes are clinically suspicious or confirmed to be involved, performing bilateral groin dissections to remove the affected nodes.
Okay, removal plus checking the groin nodes. Finally, let's cover trauma to the testes. How common are these injuries?
The testes, despite its location, is vulnerable to injury from both blunt and penetrating trauma. Blunt trauma is more common, often resulting from sports injuries, falls, or direct blows to the groin. Penetrating trauma is less frequent, but can be caused by stabs, gunshots, or other sharp objects.
What range of injuries can occur from a blow?
The severity of testicular trauma can vary widely. It can range from simple scrotal bruising or contusion to the formation of significant intratesticular hematomas, blood clots within the testis itself, to the most severe blunt injury, rupture of the tunica albuginea.
Rupture. The outer layer tears.
Yes, rupture of the tunica albuginea, which is the tough, fibrous outer capsule of the testis.
What happens when the tunica albuginea ruptures?
If the tunica albuginea is torn, the contents of the testis can extrude, and blood vessels within the testes can bleed into the space between the tunica albuginea and the tunica vaginalis, leading to a significant collection of blood within the tunica vaginalis space called a hematocele. Figure 86.21 shows a hematocele. If the rupture is extensive, blood and tissue can also track more widely into the groin and perineum.
How is testicular trauma assessed? How do you know if it's ruptured?
Assessment involves a careful clinical examination to determine the extent of swelling, pain, and tenderness, and to look for signs like bruising, skin disruption, or crepitus. This clinical assessment is crucial and is complemented by ultrasound examination of the scrotum. Figure 86.21 includes an ultrasound showing a hematocele. This source highlights that ultrasound has excellent sensitivity and specificity for diagnosing testicular rupture, making it an indispensable tool in assessing the severity of testicular trauma.
Ultrasound is key again. Is surgical intervention necessary for testicular rupture? Do you need to operate?
Yes, if testicular rupture is diagnosed or strongly suspected, early surgical exploration of the scrotum is indicated. The rationale for early intervention is compelling and supported by evidence. Surgical exploration allows for removal of clotted blood, debridement, and, crucially, repair of the torn tunica albuginea by suturing it closed.
So clean it out and sew it up.
Exactly. The source emphasizes that performing this surgical repair early is associated with a much higher rate of preserving useful testicular function compared to delayed intervention or non-surgical management of rupture. The difference is stark. The orchidectomy rate of testes removal is less than 10% with early surgical repair of rupture compared to a rate of 50% when surgery is delayed.
Huge difference. Early surgery saves testes.
Precisely. This clearly demonstrates the benefit of prompt surgical management for testicular rupture. Summary box 86.11 summarizes these key points, indicating surgical exploration for rupture or a rapidly expanding hematoma and highlighting the role of ultrasound.
Wow. That truly was a deep dive into the testes and scrotum, covering an incredible range of conditions from subtle developmental issues right through to life-threatening emergencies like Fournier's and trauma. We've delved into incidences, the why behind pathology, the critical clinical signs to look for, the role and limitations of investigations, and the nuances of medical and surgical management, including specific techniques and timings. Really comprehensive.
That's exactly right. We've extracted the essential layers of detail from the Bailey and Love text. Understanding the intricate developmental journey and what happens when it goes awry, appreciating the stark time sensitivity of conditions like torsion, recognizing the varied presentations of common swellings, understanding the different infectious causes based on patient demographics, and grasping the pathology, staging, and multimodality treatment of testicular tumors. This is the kind of detailed knowledge that moves you towards mastering this complex area, akin to the level of detail a surgeon or diagnostician would command.
It really highlights the delicate nature of these structures and the significant consequences when things go wrong, underscoring why prompt assessment and informed management are so vital. Gaining this level of depth is key for anyone aiming for a truly comprehensive grasp, whether for professional application, personal health literacy, or just the intellectual satisfaction of peeling back the layers on a complex biological system. Getting that mastery.
Absolutely. And considering how intricate the developmental path and anatomy of the testes and scrotum are, and the significant consequences when things go wrong, what does this deep dive teach us about the body's resilience and its specific vulnerabilities in even seemingly self-contained systems? It's quite remarkable how much can go wrong, but also how resilient it can be if managed correctly.
That's a great point. And also, from the critical 6-hour window for torsion salvage to the changing risks and management decisions for undescended tests or tumors over time, the timing of assessment and intervention is paramount in so many of these conditions. What does this highlight about the critical interplay between the body's processes and the limited window of opportunity medical science provides for optimal intervention? It feels like timing is everything in this area.
Precisely. It's a constant dance between biological potential and the skilled, timely response required from us. Missing that window can have irreversible consequences.
A lot to reflect on there. Thank you for joining us on the deep dive. We hope this journey into the details of testicular and scrotal conditions from the source material has been incredibly valuable for you, the listener, on your path to mastery. Keep learning, and we'll see you on the next deep dive.